Okay, so now in this lecture it shouldn't take too long. We're going to do chapters 63 and 64. That's just the eyes and the ears, and I'll break it down so that this first little series will be on the eyes, and then the second one will be on ears, so they shouldn't take too long. It's not really complicated stuff, and you're not likely to see a ton of this stuff in the hospital. These kinds of things go more to outpatient and to either the ophthalmologist or to the ENT guys. So some of the stuff that's a little more obscure, a little more vague, I'm not going to really go into, but I am just going to focus in on some of the stuff that you're probably going to see in your patients who are coming to you for something else. So some of them are a little bit more common. And those are the things that we're going to talk about. So if you look in your book on chapter 63, and I'm on starts on page 1839, a couple of words under the glossary I want you to be familiar with. This first word, accommodation, you need to be familiar with that. Basically, accommodation is the ability of the lens in the eye to change shape in order to be able to see distance or to see something up close. So if you're reading something up close, your lens has to take on one shape, and if you're seeing something farther away, your lens will adjust so that you can see that. That's called accommodation. Astigmatism is fairly common, so you should be familiar with that. A lot of people have stigmatism. Astigmatism is an unusual curvature to the cornea, and it used to be that people had stigmatism. It's more of like a football shape to the eye. They couldn't have LASIK surgery to have that corrective surgery done, but they fixed it. They've got much better techniques. So now people that have stigmatism can also have LASIK surgery. Blindness, obviously you know what that is. We're going to talk about that a little bit. Diplopia, that's a word you need to be familiar with because that just means double vision. A lot of people that have strokes will end up with diplopia, and so we're going to talk about that more on Neuro Week, so I want you to be familiar with that word. I want you to be familiar with enucleation, removal of the eye. A lot of your patients may have that because that's fairly common, especially following trauma to the eye. Hyperopia, myopia, we're going to talk about that. Palpal edema. The reason I want you to be familiar with palpal edema is because we're going to talk about it when we go over Neuro Week, and it's basically the edema in the eye, most likely due to intracranial pressure. So you'll see that word palpal edema. It's kind of like angioedema that we talked about before. Photophobia is another one. It's a neuro thing. That is where the light is so strong it bothers people's eyes. So when the light is too much and people are like, oh, turn the light up, that's called photophobia. Ptosis, dropping of the eyelids, is, I want you to be familiar with that because that's a common, sometimes an age-related and sometimes a disease-related thing. And then down here at the bottom, see where it says note, and where you might see it abbreviated. Now, we're not supposed to abbreviate anything anymore, just to reduce the risk of errors. But lots of ophthalmologists will still write down OD, OS, or OU, especially if they're writing out prescriptions. If you wear glasses or have contacts, you'll see it written out this way. And OD is the medical shorthand for the right eye. OS is medical shorthand for left eye, and OU is both eyes. So you'll see it written that way. So you should be familiar with that as a nurse because those are kind of common medical terminologies that you're going to see. Okay. The things that I want to go over in this chapter, the things we're really going to talk about, a lot of the age-related eye disorders, and there's some of them that are so common that you do need to know about them as a nurse. And we're going to go over each of them in detail, and it's cataract, glaucoma, and macular degeneration. Those are some pretty common eye-related disorders that happen as people age. The most common eye-related disorder in younger people is trauma to the eye or to the orbit. And so that's usually the cause of vision problems in younger people. Obviously, people who are diabetics are at higher risk because they can develop retinal neuropathies. We talked about this when we went over diabetes, but they can have damage to the retinal arteries and the retinal nerves, leading to diabetic retinopathies. That can also be a leading cause of vision problems. So be familiar with this figure 63.3 on the top of page 1841. That's a pretty good overview of a normal looking eyeball, and that's going to come into play when we're talking about like retinal detachments and LASIK surgery and stuff. So you need to be familiar with the different structures of the eye. All right, so the first thing I really kind of wanted to talk about, flip the page over to 1842. This figure up here on the top, figure 63.4, that is looking at the visual pathways of the eye. It's a little bit hard to figure out, but like if you looked at the left side of both of these eyes, this is the one I'm looking at right here. Can you see that? So if you look at the left side of both of these eyes, you'll see like this blue pathway, and if you see the right side, you see the white pathway. And the reason that is significant is because both of our eyes see the same things. There's some creatures like lizards, and I think owls do this, where each of their eyes can see something different, but our eyes focus on the same thing, and you can see the right and the left pathways. They end up in the back of the brain, in the occipital lobe, in the visual cortex, and you can see that in the back of the brain is where the visual cortex is, and then those cranial nerves, the optic nerves, and the nerves that control the muscles of the eye, those are all those cranial nerves up in the head. And so you can see here, if there is a problem with the optic nerve, the optic chiasm, the optic tract, or the lateral geniculate body, if you have a problem in there, and by problem we're talking about trauma, tumors, and aneurysm could rupture, and if it hits any of those spots, then you can see where the problem is going to be. So I need you to understand this pathway, but it becomes even more important if you're dealing with neuro patients and stroke patients, and then you can see why they end up with homonymous hemianopsia, because you can have half of your field of vision not working because of a stroke in one side of the brain. That's where that homonymous hemianopsia comes in. You also need to know that like the sensory part of the retina, and the retina inside the eye, that contains both the rods and the cones. The rods and the cones are important for vision. The rods are really useful for night vision. They kick in when the lights are dim. So if somebody if somebody doesn't have rods, or they have a problem with the rods in their eyes, they're going to be really bad at like night driving. They're going to need a lot of light to be able to see things. They're not going to do as well in night vision, people who have problems with their rods. People who have problems with their cones, cones are more responsible for visual, color detection, specific details and visual acuity. So people that have problems with their cones might have things not as clear, might have trouble with deciphering colors and fine details. So that's kind of the rods and the cones are sort of the meat and the potatoes of vision. To detect somebody's visual acuity, you test them with the Snellen chart. And I can't remember if there's a picture of the Snellen chart in here or not. I know you guys know what the Snellen chart is. That's the chart that's, how can you have an entire chapter on eye stuff and not put the Snellen chart in here? Anyway, Snellen is S-N-E-L-L-E-N, and apparently your book does not have that. But I know you guys know what this is. That's the chart that, the Snellen chart is the chart. It's like this, and then at the very top there's like a letter, and then and the next line down there's two smaller letters, and the next line down there's There's smaller letters yet all the way down to the bottom. And what the Snellen chart does is you have your patient stand 20 feet away from the chart. And if they can get down to the line, and it's marked on there 2020, if they're 20 feet away and they can read the 2020 line, that is considered perfect vision. And what that means is they can clearly see something at 20 feet. That's perfect vision. So then when your vision starts to deteriorate, you have the patient still standing 20 feet away, but now let's say they can't read down to that 2020 line. Let's say they can read to 2040 or 2060. And what that means, like if you have 2040 vision, that means what somebody with perfect vision can see at 2020, you are at 20 feet away. You can see, if that same person that's 20 feet away, if that person went 40 feet away, now they could see that, but you have, like the person that's supposed to be seeing if you have perfect vision at 40 feet away, the person that has 20/40 vision has to come up to that 20 feet mark to still be able to see the same thing. I don't think I explained that very clearly. I'm sure I didn't. Let me try it again. Okay, so a person that has 20/20 vision can be 20 feet away from the Snellen chart and read the 2020 line. A person with 20/40 vision has the same thing that a perfect vision person can see at 20 feet away. This person with 20/40 vision, they can, it's almost half. I mean, they would have to come in another 20 feet to be able to see the same thing. So basically, I guess you could think of it in reverse. So somebody who has 20/20 vision, they could stand back 40 feet and read the 20/40 mark, but the person who has 20/40 vision has to come up to the 20 feet to read the 20/20 mark. Does that make sense? So it goes in increments of 20 feet. And when somebody is considered legally blind, they have a visual acuity greater than 2400, meaning what somebody with perfect vision could see 400 feet away, that person has to be 20 feet away. So it's significantly bad. It's bad. And those people are called legally blind, even though they might actually be able to see stuff, their vision is so bad they're considered legally blind. And then any variation beyond 2400 is considered blind. So some people are completely blind. They cannot recognize any shapes or things. Other people can't even tell if it's light or dark outside. Some people who are blind can decipher if it is light or dark. They can tell if, like when you close your eyes during the daytime and if you close your eyes during nighttime, you can tell if there's light out there. Some blind people don't have that at all. And there's a variety of reasons for people to go blind, and we're going to talk about some of them, like macular degeneration can cause blindness, untreated cataracts can cause blindness, glaucoma can cause blindness, diabetic retinopathies, that's why a lot of diabetic people end up losing their vision, trauma can cause blindness. So there's some people at birth, just it's a genetic, that's a little bit more rare, but so there's a lot of accommodations for blind people, and they say that it's easier to be blind than deaf, because if you're blind, you can still communicate. You need some assistance, but you can still communicate with the rest of society, compared to deaf people who cannot communicate. They can see things, but they can't hear, and so now they have to use a different type of communication, like sign language. So they're only able to speak to other people who know sign language, or they have to read lips. And so they say that being blind is easier than being deaf, but I don't know. Okay, so if you are taking care of a patient who is blind or visually impaired, the thing that you need to do as a nurse, don't shout at them. A lot of nurses will go into somebody who's blind and they think they're also deaf, so they start shouting at them. Or they think that they are not intelligent, so they slow down their words. You need to just speak clearly and succinctly. If you are taking care of a patient who is visually impaired, when you walk into their room, you state, "Hi, Mr. Smith. I'm Molly. I'm going to be your nurse today. I'm going to approach the bedside now." And then, "Mr. Smith, this is me. You're going to feel me touching your hand." You just announce what you're doing. "Now I'm going to put the blood pressure cuff on your arm. Does that feel okay?" And you just, you speak through what you're doing to give them visual cues to let them know that you're there so that you're not startling them. Okay. Oh, the other thing that can lead to blindness, and you need to be careful with this because this is kind of common, is hypertension. So long-standing hypertension, can affect the kidneys, but it can also affect those the retinal arteries because of the constant pressure on there, and that can also lead to visual and acuity problems in people who have uncontrolled hypertension. Okay, let's see. Oh, here's another, I should probably tell you this. So, back to the accommodation thing. So when the lens is unable to adequately accommodate, and then your vision starts moving beyond 20/20, moving backwards to, 2100, 2150, then typically people need to wear corrective lenses, and that's what glasses do, because you'll notice the curvature of the glass, that mimics what the lens would be doing. And so when the patient goes to the ophthalmologist, finds out what the corrective prescription is, and that's when they put those things over your eyes, and the doctor will say, "Is it better with one or better with two?" They're figuring out the accommodation, and typically your eyes are a little bit different, so you could have maybe like 20/75 in one eye and 20/100 in the other eye, and they can make the glasses adjust accordingly, so then when you put the glasses on, now you've got 20/20 vision. Well, as a person ages and as that lens starts getting thicker and is unable to accommodate, then typically people who needed glasses for distance will then also need glasses for reading, because that lens has a really hard time adjusting. And there is a good picture of that in here. Yeah, it's over on page 1846 in figure 63.5. So see those pictures of the eyeballs? The picture of the eyeball at the top is normal vision. So somebody that has that is going to have 20/20 vision. So then in B, this is a myopic eye, and that is a nearsighted eye. And by nearsighted, it actually means you can't see things far away, but the reason it's called nearsighted is because when the refraction of light comes in, it hits the lens, and the lens is accommodating inaccurately in such a way that it's hitting early. It's hitting too early on the retina, making the image blurry, and that's called nearsighted, but you can't really see distance. So the nearsighted means actually where the refractory of light is actually hitting, and the image is actually hitting the retina. It's too early. Compared to C, which is a hypermetropic eye, and that means it's farsighted, meaning when the angle comes in, it's projecting it beyond the retina, so the image is going beyond the retina, and so you can't see things close up, hence the reading glasses. So this is why a lot of people, especially as they age, need bifocals. So what the bifocals do are glasses that when you look up, you can see distance, and when you look down, you've got a different shape to the glasses, and then you can read. Or you have pretty good distance vision, and then as you age, you just need, reading glasses. Except I actually had LASIK surgery, so I used to have really bad vision, and now I don't. Okay, so that's kind of eye stuff in general. Let's talk about some of the disorders Conjunctivitis is an eye disorder that is really common. Conjunctivitis is the medical terminology for pink eye. Pink eye is a virus in the eye. Really, really contagious. Classic signs are when one eye will start getting really red, it'll be itching, it can have some drainage to it. Typically what happens is then somebody will start like wiping their eye. Now you've got all the virus on there. Anything else they touch has it. And so then like in college dorms or in households, it tends to transfer a lot because it's so contagious. So when you identify that somebody has pink eye, they'll call it pink eye, we call it conjunctivitis. Really, really good hand washing. They should not be sharing washcloths. They should not be sharing towels. It usually doesn't last very long. Here's the good thing about your cornea. Your cornea is really, really sensitive. So if you get something in your eye, it hurts, it's irritated. If you get one little tiny piece of sand in there, you know it. It hurts. You can scratch it. If you scratch your cornea, it hurts really bad. The good news is your cornea heals very, very quickly. The turnover of cells in your eye and your cornea is very fast. So it hurts really bad, but it doesn't hurt for very long. So that's good. And typically somebody who scratches their cornea or has a corneal abrasion, they can use like a topical numbing stuff, but they usually only use that very short term and in the only in the hospital. They usually don't go home with those kinds of things, but they have a lot of drops, just like some over-the-counter drops, wetting drops that work pretty good. Okay, so that's it with conjunctivitis. You just really want to prevent the spread of that. Then the other things, retinal detachment. I'm going to come back. Well, let me think. All right, let's do the traumas first, and then we'll do the age-related things. So the two trauma things that I'm going to talk about is retinal detachment and enucleation. So in retinal detachment, go to page 1860. Wait a minute, I saw it. Yeah, okay, it starts on 1863. I just want to bring up retinal detachment because it's not that uncommon. What happens in retinal detachment, and if you flip over to page 1864 and you look at this figure 6310, you can see in the back where the optic nerve is coming in. And typically what happens is the retina gets torn, and that can happen because of high pressure. It can happen because of trauma. It's not painful. Sometimes it's a spontaneous retinal detachment, but the patient will complain of like a curtain all of a sudden coming down across their vision, like all of a sudden, you know, they can't see, or they'll have like massive floaters in their eye. They're called floaters, like these little yellow floaty things in their eye. And so and you can see what's going on here. The vitreous humor is like the fluid-filled part of the eye. And so there's a tear in the retina, and then some of that fluid starts leaving and filling up that retinal space. And so when your patient either has high blood pressure or has had high intraocular pressure, normal intraocular pressure is about 10 to 20. When it starts getting up high, 50s, 60s, because with glaucoma and things like that, you're at risk for a tear or in a trauma or something like that. So if the patient has those risk factors, then all of a sudden starts complaining of this vision, this curtain coming across, or these little floaty things, they're probably experiencing a retinal tear, retinal detachment. So the treatment of choice is to get them to an ophthalmologist who then will have to perform surgery. And what they do is they put a scleral buckle right around the eye, and that's shown in figure 6311. So they put that little scleral buckle around that, and what that does is it sort of compresses the outside of the eye, so the buckle will hold the sclera against the retina, and then it will repair itself. So you can read in there about how they do the surgical management of retinal tears, but retinal tear has to have surgery to fix it. And so then the other trauma that you're probably likely to see is on, let me just make sure there's nothing else in here that I want to tell you about. We're going to come back to macular degeneration. Flip over to, yeah, there's a lot of stuff in here on trauma, kind of starting on page 1867. There's a little bit in that chart 6311 about preventing eye trauma. So if your patient is doing anything risky, they need to wear safety goggles. So if they're around, like if you're sawing and there's wood chips flying up, if you're welding and there are sparks, always put on the safety goggles to protect your eyes. Really important. There's a meteorologist in the Detroit area. I think he's on Channel 4. It's not Rich Luterman. What the heck's his name? No, maybe he's on Channel 7. Anyways, you might remember this if you watch Channel 7. This was, it might have been last July. I think it was last July. It's about a year ago, where he was with his kids at July 4th, and they were doing fireworks, and sure enough, he was lighting, starting these fireworks for his kids, and sure enough, this thing went up and caught him in the eye, and he lost an entire eye. So I'll figure out his name and I'll tell you in class. I can't remember. But if you look at him now, he has a glass eye in, and that eye doesn't move as well. It doesn't blink as well. It doesn't look as well. Huge body image problem when somebody loses an eye. Although we have a lot of really good prosthetics now. They make excellent glass eyes that look very real, but they just don't move quite the same as a regular eye. So, and usually a person that has lost an eye from a trauma, they're typically able to accommodate with that other eye. It's not like the hemianopsia where they like half their field is gone. They still have like one eye that they can see out of. So they might move their head a little bit more, but they're usually able to accommodate pretty well. So anyways, you got to try to prevent the ocular trauma. But I wanted to talk a little bit more about, dry eye disease. I forgot to tell you about this. Dry eye disease on page 1870, that's sort of becoming a big deal. It's sometimes a problem after somebody has LASIK surgery where they have dry eye for a long time, but they have a lot of good drugs now like Restasis and stuff to help people with that. There is allergic conjunctivitis. That's different than viral conjunctivitis. Allergic conjunctivitis, that's just seasonal, like if somebody's allergic to pollen or mold or dust and their eyes get all red and itchy, then they can just take some antihistamines, Benadryl, normal allergy stuff. That's different than viral conjunctivitis. Obviously, allergic conjunctivitis is not contagious. Viral is. What was that? I was going to tell you something. I wanted to show, oh yeah, here it is. It's one thing about your book. I think it bounces around too much. Or maybe it's me. Maybe I bounce around. But anyways, I think I want you to flip over to page 1876. See down there at the bottom where it looks like those two eyes are staring at you? They're actually not staring at you. They're two glass eyes that are laying on a piece of foam. That's what a glass eye looks like following an enucleation, removal of the eyeball. They will match up the new eye, so they can make it whatever color and to get it to match. But that's what they look like. You can tell they look really real. So those are eye prostheses after somebody loses an eye. Okay, so the rest of this, let's focus on these age-related eye disorders because they're kind of common. So the first one I want to talk about is cataract. Cataracts is basically where the lens of the eye, and it starts over on page 1857. The lens of the eye, which is normally supposed to be nice and clear, starts getting really cloudy, and you can see it when you look at somebody. This is really common in dogs too. So if you have an old puppy, an old dog, you'll see when you look at their eyes, they start getting really cloudy. It happens in people too. There's not really a treatment or a prevention for it. It's just kind of an age-related thing, pretty common as people age. The only thing that you can do for that is surgery. And what they'll do is they just go in and they just remove the lens of the eye, and then the person can typically see, because people that have cataract is like looking through fog all the time. I don't know if they have a picture in here. Some of them, I guess not. Some of these have pictures of what it looks like, but people that have cataract just end up looking through fog. But the surgery is really easy. They can just go in and remove that, and that's usually okay. The next thing I wanted to talk about is macular degeneration. Now let me find out where that is. Macular degeneration tends to run in families. So if you have somebody in your family that has macular degeneration, your tendency to have it goes up. Studies have shown that there's not a lot of vitamins and stuff that help with a lot of eye things, except with the macular degeneration. There is some suggestion that some of the eye vitamins, the lutins, the fish oils and stuff, may help slow it down a little bit. There's not a cure for it. There are two types of age-related macular degeneration. There's a dry and a wet. The dry is more common. Sometimes people can have both. You know, they can have dry in one eye and wet in the other. And what happens with the age-related macular degeneration, there is a good picture of what it looks like. I'm on page 1866 now in this figure 6314. So you can see how it's just blurry, and some parts of it are fuzzy, and they lose some vision in their visual fields, and things like straight lines will appear kind of blurry and fuzzy. They might be reading and it looks like some words are broken on the line. That is macular degeneration. Again, fairly common, especially in the elderly population and as people are aging. So read up on your macular degeneration, because that's another one that can lead to blindness. So you need to be careful of that. And then the third and final thing that we're going to talk about with eye disorders is glaucoma, because glaucoma is also a fairly common age-related disorder. Okay, now let me find out. I think glaucoma, hang on. Oh yeah, here it is. Okay, glaucoma starts on page 1852. Oh, and by the way, if you don't know how to help somebody put eye drops in, or like an eye salve, you can see it on chart 63.5 there. That's how to help somebody put eye drops in. Okay, so glaucoma. The problem with glaucoma is that is a pressure-related disease, and what happens is the vitreous humor in the eye, which is supposed to drain fluid all the time, it gets clogged. It's like your kitchen sink, and then the drainage system starts clogging. So sometimes you can have just like the clog is just starting to get sort of sludgy, and so your sink will drain, but it just takes a lot longer. And other times, like, you'll put a stopper in the sink and the whole thing stops up immediately. That one's obviously a little bit more difficult to manage because it comes on much quicker. Oh yeah, over here on figure 63.6 on page 1854, this is an example of glaucoma, and there's two kinds of glaucoma. There's closed and open angle glaucoma, and basically all that means is where the stoppage in the drainage system is occurring. And people that start developing glaucoma, you see down here at the bottom page on figure 63.7, their field of vision will kind of start going like this. So it gets dark on the outside and it's lighter right in the center. But the problem with that increased pressure is kind of like having increased blood pressure, is if you don't relieve the pressure, then sometimes you can have damage that is irreversible. So you need to identify the problem and get it treated so that you don't cause irreversible damage. And up here in table 63.4 will tell you the different kinds of glaucoma and the different types of treatment for glaucoma. Okay, I think, yeah, you do need to know, let me just look here for a second, because there is some medical treatment for glaucoma, like they can give, oh yeah, here it is, the ocular hypotensive drugs, they can give cholinergic drugs. The cholinergics will increase the outflow of fluids sometimes, so typically people that have glaucoma have to stay on these meds for the rest of their life. There's not really a cure, there's only treatment for glaucoma, and you want to prevent that fluid from increasing pressure. So you're going to, it's constantly like if you know there's a clog in your drain, you just constantly have to keep Drano in it to kind of keep it open. That's what people with glaucoma, that you just always have to treat it to make sure that that stoppage doesn't occur again. So really the thing with glaucoma is to keep that pressure under control so that there's no more ocular damage. So kind of look over some of the treatment medications for glaucoma. And let me see. Oh, table 63.5 has a lot of good meds on it too for that they use for glaucoma, like the cholinergic. Sometimes they'll use the beta blockers, so that's a good table to know. All right, I think that's it. That's all we're going to go over. There's not really a lot of there's a section in this chapter about eye tumors. Those aren't super common, so we're not going to go over that. It's you know, if you end up working like in an ophthalmology clinic or something, you'll know all this stuff inside and out. But really for the general public, for the general med-surg nurse, those are the big things. You know, blindness, diabetic retinopathy, cataracts, macular degeneration, and glaucoma. Those are the things you're going to probably see when you're taking care of a patient with something else. The corneal injuries, LASIK, everybody's probably already had that. I think that's really all you need to know for this chapter. Ocular burns, we talked about that, and burn week. Yeah, that's really all you need. You don't need to know the rest of this stuff. It's just, yeah, that's, okay. So if I talked about it, study it, review it. If I didn't, move on. We don't have to do that. Okay, so I'll turn this off and then we'll start on Chapter 64, we'll do hearing. Okay?